بسم الله الرحمن الرحيم. أنا يسعدني ويشرفني أن أنا أشارك في رئاسة هذه الجلسة من الاجتماع السنوي لجمعية الهايبرتنشن، واحدة من أعرق الجمعيات المصرية. ومتحدثنا اليوم الأستاذ الدكتور محسن إبراهيم، وهو غني عن أي تعريف، وهو منشئ الجمعية ومؤسسها ورئيسها. وهيكلمنا النهارده على موضوع يعني ليه اهميه خاصه بالنسبه لي، وهو هايبرتنشن اند الدرلي. دكتور محسن.
شكرا دكتور خيري. I will address the following questions. What is the definition of elderly? Whom we call elderly? At what age we define elderly? This is the first question. The second question, why hypertension is more common in the elderly? What are the underlying mechanisms? Why we develop hypertension when we get old? Third question, what are the hemodynamic and the clinical characteristics of hypertension in the elderly? What is special about hypertension in the elderly? The fourth question, what are the challenges that we meet in the management of hypertension in the elderly? And finally, treatment. Whom to treat, to what target, and which will, and with which drug class. These are the 5 questions which I'm going to address during my presentation. First of all, we have to realize that age is a very important risk factor for hypertension. Why hypertension in the elderly? Why is it important? First of all, we have to realize that worldwide, life expectancy has increased significantly. At the beginning of the 20th century, the average life expectancy was between 30 and 45 years. At the end of the century, it averaged about 67. So we are getting old and we are aging. In 20 years, the aged population is estimated to exceed almost 20% of the whole population. Hypertension is the leading cause of cardiovascular morbidity and mortality in adults over the age of 65. The estimated prevalence of hypertension in the elderly is around 60 to 75%. This means that almost 3/4 of elderly individuals suffer from high blood pressure. And the systolic pressure shows a continuous increase between the ages of 30 and 84. In contrast, the diastolic pressure has a varying pattern with aging. It increases until the 5th decade and then is slowly decreasing from ages 60 to 84. These data are from our own Egyptian National Hypertension Project, a nationwide survey which we conducted in the early 90s. And you can see the systolic and diastolic pressures over the different age groups in both men and women. The systolic pressure is rising with advancing age, while the diastolic pressure remains stationary and it declines in the old age. This is the prevalence of hypertension, again from our own data. And you can see that the prevalence of hypertension increases in old age. Above the age of 65, more than 60% of the Egyptians suffered from high blood pressure. Then we come to the first question, whom we call elderly. What is the age that defines old age? The United Nations put old age officially at age of 60. However, old age can be defined between 60 and 65. We have another term, which is the very elderly, which is defined by more than 80 to 85 years. The second question, why hypertension is more common in the elderly? Why? What are the mechanisms? What makes elderly individuals vulnerable, more likely to develop high blood pressure? There are 4 different mechanisms that can lead to the development of hypertension as we get old, as we advance in age. The first and possibly the most important mechanism is the increased arterial stiffness. As we get old, our arteries get stiff and rigid. Second mechanism is endothelial dysfunction. The vascular endothelium becomes diseased, and when it becomes a disease, its ability to generate nitric oxide diminishes. And then when nitric oxide diminishes, vasodilation is less, and there is a tendency for prothrombotic and inflammatory states. Also with aging, there is a pro-inflammatory state. As we get old, the systems in our body are towards inflammation. And finally, an important mechanism is sodium retention. With aging, there is a tendency for sodium retention. This is a section in the artery, and it shows that in the elderly, there is increased collagen deposition in the wall of the artery. There is loss of elastic tissue. There is adventitial remodeling and endothelial dysfunction. 2 sections, one in a young, healthy artery, you can see the media and the lumen, and in the aged elderly, you can see that there is a thickening of the wall, and there is vascular remodeling, increased stiffness, inflammation, calcification. Aging is associated generally with metabolic syndrome, with increased tendency to inflammation and neurohormonal disorders, and these will lead to arterial stiffening and hypertension. The arterial stiffness arises as a consequence of wall hypertrophy and in changes in extracellular matrix. Sodium retention. As we get old, as we advance in age, our kidneys lose their nephron population. And when we lose our nephrons, there is a tendency for salt retention. And with salt retention, there is an increase in plasma volume. And with the increase in plasma volume, there is a rise in blood pressure. Other mechanisms that contribute to hypertension in the elderly is a sleep apnea. By sleep apnea, this is interruption of sleep with interruption of breathing with the sleep, with hypertension. And also with aging, chronic renal insufficiency and obstructive nephropathy and thyroid disease. The third point, what is special about hypertension in the elderly? How is it different from hypertension in other age groups? What are the clinical and hemodynamic characteristics? There are blood pressure changes with aging, and there is increase in systolic pressure, mean arterial pressure, and pulse pressure. The most prevalent class of hypertension in patients greater than 50 years is isolated systolic hypertension. The clinical and hemodynamic characteristics can be age-related and hypertension-related. The age-related changes include left ventricular hypertrophy independent of age. As we get old, we are vulnerable. We are likely to have left ventricular hypertrophy. Again, there is delayed excretion of salt and volume load impaired ability to maintain normal fluid volume. As we get old, we get frailty, we get weak. And also, we are vulnerable to cognitive impairment. And we are more likely to have comorbid conditions such as diabetes mellitus, orthostatic hypotension, prostatic hypertrophy in males, psychic depression, osteoarthritis. The hypertension-related characteristics include increased systolic blood pressure and pulse pressure. And with advancement in age, the systolic blood pressure rises and the pulse pressure increases. There is blood pressure variability. As we get old, our blood pressure is liable to changes. The diurnal changes over the 24 hours, or postural changes. When we stand, blood pressure is liable to drop. And postprandial, after a heavy meal, the elderly individual is liable to have a drop in his blood pressure. Also, with age and with hypertension, we have the common comorbidities. Hypertension in the elderly is associated with diabetes, chronic kidney disease, obesity, atherosclerosis, and psychic depression. Target organ damage is more likely with hypertension in the elderly, whether cardiac, renal, coronary, vascular, and retinal. Sleep apnea, another problem, and polypharmacy. Target organ abnormalities are more likely to develop in the hypertensive elderly. Asymptomatic carotid bruit, and this is associated with increased risk of a stroke. Systolic cardiac murmurs, either due to aortic valve sclerosis or mitral regurgitation. Irregular cardiac rhythm. Atrial fibrillation is more common in the elderly. Premature atrial contractions, premature ventricular contractions. Abdominal bruit as a result of renal artery stenosis and aortic atherosclerosis. Prominent abdominal aortic pulsations, possibly abdominal aortic aneurysm, and signs of peripheral arterial disease. Then what are the challenges in the management of hypertension in the elderly? We have a number of challenges in management. Multimorbidity, I refer to the multimorbidity already in my presentation. Polypharmacy, the old individual is more liable to have many drugs. Frailty, we'll come to this point later on. Liable to orthostatic hypotension, and this is associated with falls, and he can injure himself. And finally, cognitive impairment, dementia. Multimorbidity, this is the presence of 2 or more long-term conditions, and it is present in 65% of those aged 65 to 84, and 82% of those aged more than 84% have 2 or more morbid conditions, such as diabetes, dementia, atherosclerotic disease, etc. At least 2/3 of hypertensive patients have another comorbid conditions. As I've mentioned, diabetes, coronary dyslipidemia, heart failure, chronic kidney disease, atrial fibrillation, obesity, obstructive sleep apnea, gout, aortic stenosis, and depression. Polypharmacy, another problem in old age. The old individual is vulnerable, is more likely to take a number of medications, and this will lead to falls, electrolyte disturbances, hospitalization, heart failure, raised blood pressure, and premature mortality. Frailty. What is meant by frailty? This is, as a matter of fact, one of the manifestations of aging, الوهن, reduced physiological reserve, leading to increased vulnerability to physical stressors, feeling tired, fatigue, difficulty in walking, and weight loss. Potential risks of causing harm by lowering the high blood pressure. So the frail individuals is more liable to have problems with antihypertensive medications and with lowering of his high blood pressure. And the very old and frail individuals, a low blood pressure underperfuses vital organs. So it is mandatory, it is essential to look for frailty before initiating antihypertensive drugs. And patients with frailty to be initially treated with monotherapy. When systolic blood pressure drops below 140, blood should be reduced as much as possible. No more than 2 antihypertensive drugs should be prescribed. And finally, the question of treatment. Should we treat hypertension in the elderly? Which drug? At what level? What is the target? So we have here 4 questions: whom to treat, which is the target blood pressure, and we have to stress the lifestyle and dietary approach, and the final question, which drug to use. Before starting treatment, we have to assess orthostatic reaction. As I have mentioned earlier, the elderly is vulnerable to have postural hypotension liable to fall. Therefore, blood pressure should be measured first in supine, followed by upright position. The measurement should be confirmed by home self-measurements to better assess blood pressure level and eliminate white coat reaction. Again, I'm stressing the fact that hypertension in the elderly is liable to fluctuations. Elderly individuals are liable to have variability, excessive variability in their blood pressure from day to day, from hour to hour, from minute to minute. The guidelines for blood pressure goals in adults over the age of 60, persistent systolic blood pressure 150 or more should be treated to achieve a target systolic blood pressure of less than 150. This is whatever the age of the individual. History of a stroke or transient ischemic attack may be treated to a lower target blood pressure less than 140 to reduce the risk of recurrent stroke. A high cardiovascular risk, diabetes, chronic kidney disease may be treated to a lower target pressure. We have to carefully titrate antihypertensive therapy in the standing position. The isolated systolic blood pressure should be the primary target for diagnosis and management, because the basic problem in this population of the elderly is the isolated systolic blood pressure. There is no age threshold beyond which hypertension should not be treated. So we have to treat all the elderly hypertensive, but be careful in the very elderly and in the frail hypertensive and those with postural hypotension. Systolic pressure more than 160 or diastolic pressure more than 100 will generally require 2 or more agents to reach goal. Lifestyle modification is important, and this is possibly maybe the only treatment necessary for preventing or even treating milder forms of hypertension in the elderly. What's meant by lifestyle modification? Weight reduction, DASH diet. I think all of us know now what is meant by DASH diet, and dietary sodium restriction. Physical activity is recommended. Brisk walking at least 30 minutes per day, most days of the week. As a matter of fact, this physical activity and this brisk walking is useful not only for hypertension, but also it has been found to prevent coronary disease, to delay dementia, and to prolong life. The drug treatment, low-dose thiazide diuretics remain the first line of therapy for older patients. Other drugs are recommended depending upon the comorbidity and risk factors. The general rule when you give drug treatment for elderly patients is to start low and go slow. There are definite risks of pharmacologic therapy in all the elderly. Decreased baroreceptor activity will lead to orthostatic hypotension. Impaired cerebral autoregulation will lead to cerebral ischemia and falls. Decreased intravascular volume will lead to orthostatic hypotension. There is sensitivity to hypokalemia, which makes the individual vulnerable to arrhythmias and muscle weakness. Decreased renal and hepatic functions will lead to drug accumulation. Polypharmacy will lead to drug interactions. And CNS changes, depression, and confusion. So in summary, a large number of elderly hypertensives is expected in coming years. We expect to see more of the elderly hypertensive patients in the coming years. The mechanisms include arterial stiffness, endothelial dysfunction, sodium retention, and pro-inflammatory state associated with aging. Blood pressure variability. This is quite common in the elderly hypertensives. Postural changes, increased prevalence of associated cardiovascular risk factors, and target organ damage are common. Treatment includes limiting sodium intake, control of obesity, use of thiazide diuretics as initial steps. And thank you for your attention.
شكرا استاذ دكتور محسن، محاضرة جميلة. everything is clear. انما انا يعني عندي مشكلة في المانجمنت وهايبرتنشن في الالدرلي، وهو ان as you said mainly systolic hypertension. الدايستوليك بيبقى طبيعي وفي بعض الأحيان يبقى واطي. وأي تريتمنت للسيستوليك بلاد بريشر will further lower الدايستوليك بلاد بريشر. فهل في حد الدايستوليك بلاد بريشر ما تقدرش تعالج السيستوليك تضطر تسيبه 170 على ساعات بيبقى 70 على 70 مثلا؟ دي مشكلة. المشكلة الثانية في موضوع انت قلت ان في صوديوم ريتنشن، decrease excretion sodium increase the fluids. فالدايوريتكس مشكله. اولا هي ما هيش جايد لاينز، وثانيا العيانين دول عاده كتير اللي عندهم بروستيت يقوم بالليل منهم يروح دورة الميه يقع. فيعني استخدام الدايوريتكس يعني محاط بمحاذير في الالدرلي بالذات.
Thank you for the questions. هو في حقيقة الأمر, as a matter of fact, the guidelines recommend thiazide and thiazide derivatives as the first line recommended therapy for hypertension in the elderly, unless there are specific indications for other drugs. And as a matter of fact, there was a study that was published some years ago regarding treatment of hypertension in the very elderly. Very elderly, those patients whose age is above 85. Should we treat these patients? And if we are planning to treat them, which drugs? This is known as the HILET trial. And these were patients older than 85 years, hypertensive. And they found that these patients should be treated, and treatment improved the outcome. And the drugs that were given were the thiazide diuretics. And if not controlled, there was an addition of an ACE inhibitor. So this is proved that thiazide diuretics are the drugs of choice. And there is no wonder, because in this population, there is tendency for sodium retention because of the diminishing nephron population. So the elderly are liable to retain salt and water, and this is possibly the basic mechanism, in addition, of course, to increase arterial stiffness. What was the first question? Yeah, yes, this will be a dilemma, but still you have to, as I have mentioned, to start with a small dose and to go slowly and to try to handle, not to go with very low diastolic pressure, and less than 6 is not accepted. But again, you cannot leave with systolic blood pressure more than 170.
Thank you very much, Professor Mohsen Ibrahim. I'd like to congratulate Professor Mohsen Ibrahim, the president of the Egyptian Hypertension Society, Professor Muhammad Abdel Ghani, the chairman of the meeting, and all board members of the Egyptian Hypertension Society for this excellent meeting, a wonderful program, a distinguished group of faculty attending this meeting this year. So for the sake of time, because we have a virtual session and the speaker is online, we have to close this session. Thank you very much.